At Talus, we know cybersecurity can be tough and you can't protect everything, but with Talus, you can secure what matters most. With Talus industry-leading platforms, you can protect critical applications, data, and identities, anywhere and at scale with the highest ROI. That's why the most trusted brands and largest banks, retailers, and healthcare companies in the world rely on Talus to protect what matters most: applications, data, and identities. That's Talus, T-H-A-L-E-S. Learn more at talusgroup.com/cyber.
It's back to school season, and Clorox is donating 2 million disinfecting wipes to classrooms across America. Because back to school means things can get a little bit messy. Just ask kindergarten teacher Miss Gibson.
Give me just one Clorox wipe and I'm ready for glitter glue, exploded lunchbox yogurt, peanut butter handprints, runny noses, picking noses, rubbing noses.
Touching noses.
Thank you, Edward. Ooh, nap mats and lockers and tissue boxes. And
Clorox
scissors.
disinfecting wipes. Teacher's #1 wipe. Clean feels good. Based on unit sales data.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing different patterns of screen use and suicidality. So, John, how are you doing tonight?
I am tired tonight. How about you?
I'm doing fine. You look perky, so if you're tired, you're hiding it well.
All right. Yeah.
The life of the family doctor.
I'm ready to do this, though.
Yeah. Addiction medicine perks you up, right?
Yeah.
Anything you want to share with our listeners tonight?
I hate to share in a highlight an article, another article. I'm not sure if you saw our recent Journal of Addiction Medicine. I thought there was a really very concise synopsis. And it was an article called "The First 100 Days: The Trump Administration and Changes of Addiction Policy." Did you get a chance to see that?
I saw the headline and I was just so depressed I couldn't read it. So tell me, what did it say, since I didn't read it?
Yeah, I mean, I always like to I feel like it's a relatively non-biased source. I want to hear what they say or what they put the highlights were. And here's the highlights. They talked about the first 100 days. They talked about kind of new priorities. So a reprioritization of drug policy, really focusing more on fentanyl supply and youth drug use over kind of implementation of alternative programs. So kind of back to a source control mentality, not our youth mentality. They talk about big restructuring here. I think we all are aware that SAMHSA, HRSA, and a few other branches have kind of been disbanded, and they've been actually kind of remerged. And I actually didn't know this, that they've been remerged. This is called the Administration for a Healthy America. Did you ever hear of that before?
No, I know about Make America Healthy Again.
Well, I guess this is what the overarching group is going to be called. Other things was there's over 20,000 staff cuts at HHS. Positions were eliminated. They talked about especially kind of weakening what they felt was federal addiction expertise and key data collection programs, a lot of our epidemiology and tracking. Funding reductions. So they talked about roughly several billion clawed back from addiction grants. But they say that overall, they don't really understand if that is just kind of contemporary pandering or true funding cuts that are going to transpire down to the kind of the troops on the ground. Medicaid at risk, so the $880 billion in cuts threaten addiction treatment cover, since kind of state coverage really is a large portion of our patient population that we care for. Interestingly, they talk a lot about data loss. So, critical systems like NSDUO or NSDUH and Dawn face elimination. They talk about that's kind of a data tracking policy and programs, and it jeopardizes kind of policy planning because we don't have kind of some of this data to guide decisions like we currently do. And then lastly, not surprisingly, termination of many NIH grants, especially anything related to diversity, HIV, AIDS, and addiction. And there's a lot of overlap in those groups.
Are they purposefully cutting programs relating to HIV AIDS?
I think it's tough because, the talking to someone that's been involved with policy at our the conference we spoke at, they talked about the fact that essentially they've got people going through all these grants. And if there's certain buzzwords involved with the grants, they just do basically a search all of documents and they just terminate if they find any of those buzzwords in the document grants. They're not really reading context. At least that's what I was told.
Mhm.
And certainly, I think it's hard to treat HIV and AIDS kind of working in that space without kind of acknowledging that that group is a minority group for the most part of some form. So they're a vulnerable population. Um, and so I think they're a little targeted with some of this actions against diversity.
Mhm. Oh, so what do you think? What conclusions did you draw from this?
I mean, it sounds like a lot of like talk with like people willing to kind of understand the downfall, like in the future. It doesn't sound optimistic.
Yeah,
Like,
right.
let me just, not for what I do.
Well, right. I mean, for us, it's like the lifeblood of our patients and our practices and our business is, patients with insurance and mostly with Medicaid. And if those patients don't have insurance, then their access to care is going to be significantly impacted. Our health system's reimbursement will be impacted. Who knows where the money will come from to continue to care for those patients.
Well, I mean, I think you're still going to see it. I think you're going to see in different settings, right? I think you're going to see acute care hospitalizations. They'll still be reimbursed. I think you're going to see ED visits. They're going to be reimbursed. I think that you're kind of going to see less kind of underlying treatment of the problem and more just kind of the outcomes of the problem,
Yeah.
right? Because by law, EMTALA, we got to take care of these people when they walk through the door. Um, However, we could have probably prevented this.
Well, sure. But, you know, yeah, I mean, I just remember when I started working at St. Max's, about 30% of our patients were uninsured. And that's almost unthinkable now. I don't know the exact percent, but it's much, much less. I mean, when you think about your office visits, like in a day, how many of your patients don't have insurance? It's pretty low in our area now, So, well, we'll see. I have to see what the next 100 days holds.
How about you?
So a little bit of good news maybe coming out of our current health administration. So you'll like this. I was reading about how on July 29th, the FDA announced that it was going to make 7-OH, which is hydroxymitrigynine, the kind of active ingredient in kratom, to make it a controlled substance. FDA's commissioner, someone named Dr. Marty McCary, he wrote a dear colleague letter to us. I don't know if you got your copy personally, but warning us about the dangers of hydroxymitragynine. And actually, it contained this interesting line. He said, he's a physician. He said, like many physicians, I find it painful to recall the many opioid prescriptions I wrote in the early 2000s for routine procedures, unaware of the high potential for abuse. Our recognition of the abuse potential and our delayed response as a medical community resulted in a national health crisis. Let's not get caught flat footed again. We rarely hear a personal apology from a medical official, especially someone kind of high up in leadership like that for what we did. And it seems like his early experiences or his experiences in the 2000s really affected how he wants to approach this new opioid that's being sold over the counter right now. And they do distinguish between the hydroxymitragynine, the 7-OH, and kratom, which is a natural product. They include concentrated tinctures as an okay product. But the 7-OH, which is a kind of a semi-synthetic, is what they wanna target. So the next step is to send the recommendation to the DEA and see what happens if the DEA wants to make it a controlled substance. So, John, do you think this 7-OH should be a controlled substance?
Yeah, I think that since we first covered this, it's funny. This was something I think we dipped our toes into, and I see a lot of it. I actually just had a new patient yesterday that they were really upset that someone recommended that they have a history of substance use disorder, kind of in remission off medication for decades, and someone recommended this product to them to help them feel better. Um, and then they noticed after a while of taking it, they needed it more. They kind of experienced the euphoric effects. And then they realized what it was. And they were really upset that this is being sold. And the person now is kind of back into treatment with me, like totally back to where they started. And
Mhm.
he was really mad. And I
Yeah.
think that this doesn't belong on the shelves. I mean, it
No, I
doesn't.
don't
It needs to be regulated.
at least this concentrated product. I mean, you could talk about kratom, which also should be regulated and maybe not even be sold over the counter, although then you get into all the people who use it kind of recreationally and enjoy it. Should we, like any products, many products we sell are lethal. in various doses. But I do think this one particular chemical has got to go. It's just not doing us any favors as a country. And millions of Americans are using these products right now. So that's something good, maybe. We'll see what the DEA says. So, John, you ready to present your article?
Sure. Yeah, I think that this was kind of a fun article. I actually liked presenting this in our live journal club last week. I thought it actually generated a lot of discussion. And actually, it's a little different than what we normally do, right? So I think we spent a lot of time talking about opioids, alcohol, tobacco, nicotine. Actually, this is like a different form of addiction. So this is an article called Addictive Screen Use Trajectories and Suicidal Behaviors, Suicidal Ideation, and Mental Health in U.S. Youth. It's from JAMA from July 2025. And kind of like before I start, Sonya, how much time is on do you use your phone today?
So I trying not to use my phone. I use my phone an hour and 25 minutes today. And that doesn't include anything for work because I have a separate, different work phone. So this is just my fun phone, literally an hour and 25 minutes. I have no free time. And yet I found an hour and 25 minutes to mess with my phone.
Yeah. So like this is going to be like shameful, but like my phone is both my work phone and my pleasure phone. And I do use it for like ambient dictations, but I'm over 12 hours already today.
Ooh,
So yeah.
12 hours with the screen on.
Yeah.
And
So
how much of that is epic?
well, a lot of I mean, like I said, I can't sort out the ambient dictation stuff, but 12 hours on the phone, I feel like a not a good person right now.
Oh,
All right.
all right. With that said,
With a little bit of background here. So, increasing use of social media, video games, mobile phones, and screens among adolescents is increasingly being linked to suicidal behavior and mental health issues. Concerns have led to warnings, including one from the U.S. Surgeon General. Most research is focused on total screen time, but not really addictive screen use, which may be a stronger risk factor for suicidality and poor mental health outcomes. Addictive use can differ by platform and does follow different unique developmental patterns. These addictive use trajectories in youth are not well understood. And so this article meant to kind of not only understand kind of the effect on these outcomes, but like what do these different use trajectories actually look like? So the clinical question here was, are longitudinal trajectories of addictive screen use, so that's social media, mobile phones, video games, associated with suicidal behaviors, suicidal ideation, and mental health outcomes? And they talked about internalizing and externalizing symptoms in U.S. use. So a little about the study. This was a prospective cohort study using data from 4,285 youth in the Adolescent Brain Cognitive Development Study. That's the ABCD study. And that was conducted across 21 U.S. sites to examine the association between addictive use of social media, mobile phones, and video games, and subsequent suicidal ideation, behaviors, and behavioral symptoms over a 4-year follow-up. So a little bit about this kind of overarching ABCD study. It was a nationwide population-based longitudinal cohort study. The total study involved 11,868 children aged 9 to 10, and it was from 21 different U.S. cities and sites. And it followed them annually from 2016 to 2022 to examine things of brain development, mental health, and behavioral health outcomes across adolescents. So the population of this data analysis was a subset of 4,285 out of that 11,868 children ages 9 to 10 with complete screen use data. So basically data used from years 2 to 4 of the Perspectives trial. Inclusion was children with complete data on addictive screen use measures from year 2 to year 4, available baseline demographic and clinical data also being available. Participants were excluded if they didn't have the 4-year follow-up data or incomplete data on key measures like screen use or outcomes. Participants with missing baseline demographics or clinical characteristics were also excluded. So a little bit about the study protocol. So like, as I said, it was a longitudinal cohort grouping. It followed annually from 2016 to 2022. And participants started at ages 9 to 10 at enrollment. So addictive screen use was assessed at age 11 to 14, so that's years 2 to 4, using self-reported scales. And they looked at the social media addiction questionnaire, that's the SMAC, the mobile phone involvement questionnaire, the MPIQ, and the video game addiction questionnaire, the VGAQ. Suicidal ideation and behaviors were assessed at age 13 to 14 using the KIDDIE schedule for affective disorders and schizophrenia, that's the KSADS, via child and parent reported symptoms. Mental health outcomes were also measured at age 13 to 14 using the child behavior checklist. And that was only parent reported. The
So
primary
basically, like lots of surveys.
yeah, pretty much. Yeah, I mean, this is data collection with surveys, right?
Okay.
So the primary outcomes were suicidal ideation and behavior, and that was assessed at 4-year follow-up, and that was using that Kitty schedule for affective disorders and schizophrenia, and that was both child and parent report, and then also internalizing and externalizing symptoms, measuring using T-scores from the parent-reported child behavior checklist. They did do statistical analysis looking at different modelings of use, which I thought was very interesting. And if you actually get some time to look at this article, looking at the different use trajectories that they came up with was actually kind of interesting to see. And they kind of tried to adjust for a lot of the covariates that typically we talk about, such as those baseline demographics and characteristics, along with just total screen time as well. So the question is this trial valid? The study was funded by NIMH and the American Foundation for Suicide Prevention, so there was no industry funding here. One author had a non-industry conflict of interest that was royalties from the Columbia Suicide Severity Scale and the Pathway app, which I thought was interesting because I didn't realize that that was proprietary. I think that I see that cited in like every chart I get from one of my counselors. It's a large prospective cohort study, so over 4,000 youth across 21 U.S. cities. So that's a pretty large trial. And it did kind of look at this association, as we discussed, between digital media use and suicidal ideation, behavior, and symptoms over the 4 years. And they did talk about how kind of previously data regarding social media and mental health outcomes was cross-sectional. So this was kind of a nice longitudinal assessment, which is kind of missing from the data. Data was self-reported with no objective measures that may introduce an amount of recall bias. And also, you talk about social desirability bias. And I think that really comes into play when you talk about parental recall, right? I think a lot of parents want to love their children. They want to speak the world about them. I think that there is probably, I think all of us maybe don't always want to report it as kind of candidly when maybe our child acts outside of what we would consider socially desirable norms.
Mm-hmm.
Mental health is assessed using the parent-reported child behavior checklist, which may underestimate mental health outcomes in subjects. So, could the parent actually be unaware that this child had kind of internalizing and externalizing symptoms that they weren't voicing to the parent? I think that's kind of a very valid critique that the author actually mentioned about it. We always have like the COVID-19 pandemic, like X factor involved here, right? So that was a unique time for being a kid and being a human being in this country. So they do talk about like probably screen use that during that time period was probably not reflective of kind of true screen use. I mean, I don't really watch TV that often. And I can't tell you how many Netflix shows I watched during that time frame, including Tiger King. And that's something I would never like rot my brain to another time. So we did have different screen use patterns then. Data was derived from 4,000 subjects who had completed all 4 years of the study to date. So that was out of 11,868. So, I mean, it's a large sample, but it is kind of, when you look at it, it's basically a third of the total participants were included. So, there's a possibility of selection bias, but I do think with an N that high, it's probably unlikely. Analysis did not include other things that I think would be useful, like psychosocial and behavioral health factors, like bullying, adverse childhood experiences, parental monitoring, sleep disturbances, social stressors, isolation, social determinants of health. I mean, we know that those are all strong factors associated with the primary outcomes. It would have been nice to see some inclusion of that to see if there is a relationship between maybe those variables and screen time and suicidality, or if these are truly all independent, or is there overlap?
Right, whether it's just the screen time is just sort of a stand-in for some of these other things. And so, right, because in the end, you're looking for points to intervene. And if it's not really the screen time, if it's actually bullying that leads to lots of screen time, that leads to suicidality, you got to intervene at the right spot.
Exactly. So kind of a little bit about the results here. So in terms of the demographics, the sample, we said over 4,000 participants. The mean age was 10. In terms of sex, 47.9% were female, so roughly 50-50 by gender. For race and ethnicity, almost 60%, 58.7% were white, followed by 19.4% Hispanic and 9% Black. 40.2% were from households earning less than $75,000 per year. So I mean, 60%, majority were from households making more than that. 34% of parents had less than a bachelor's degree. So I thought this was kind of interesting. So, certainly the majority of the participants here were from households where the parents were at least to some degree educated and had a relatively decent household income, at least at the time. In terms of addictive use trajectories and prevalence, in terms of trajectories identified, the social media and mobile phone use, we really had three identified trajectories: a low, an increasing, and a high trajectory, while video games kind of just followed low and high. In terms of prevalence of these, 31.3% had increasing social media use between that age 11 to 14. 24.6% had increasing mobile phone use, and 41.1% had high video game use. I think kind of the first interesting thing that came out of this study was that in terms of baseline total screen time, just kind of like your baseline, how much were you doing? There was no statistically significant association with suicidal behavior, ideation, or mental health outcomes, and that was statistically significant. So I think that was interesting. That kind of just the N where you start at this age group doesn't necessarily have a strong prediction, which I think counters some of my preconceptions.
Well, right. And whenever we hear about the dangers of screen time or articles about screen time, it's all about just reducing the time you spend with your screen.
Yeah, definitely. There is a really good graph I would encourage anyone to look at, but basically it kind of looks at these kind of patterns. And really what you kind of see is for social media use, you have like a high, a low, and then you have this kind of high peaking use trajectory where people kind of have like an increase and then kind of a decrease around age 14. Vice versa for mobile phones, you have three trajectories: high, increasing, and low. And so almost like an exponential group in the middle that's kind of taking off with the group that seems to be at a high risk group. And then I think it was interesting, like video games, you're kind of in or you're out. You're like a high or a low user. And I thought that was
Hmm.
kind of interesting. There was, with us talking about like DSM criteria for a possible like video game addiction, you would think that if it truly was an addictive pattern, that there would be some sort of exponential relationship like some of these other things, at least in a subgroup. In terms of suicidal outcomes, so one of the primary results here. So this was kind of year 4, so kind of assessed at age 13 to 14. In terms of prevalence, I actually found this as a parent of a 10-year-old heartbreaking, that the prevalence of suicidality, so overall, there was a 5.1% reported suicidal behavior at age 13 to 14, and just shy of 20%, 17.9% of kids this age group reported suicidal ideation.
Yeah, that's super high.
It's
Yeah.
heartbreaking.
Yeah.
In terms of social media use, so the increasing trajectory, there was a strong relative risk increase, 2.14, that was statistically significant for suicidal behaviors. As was the high peaking group, there was a very strong statistically significant increased relative risk of 2.39 of increasing suicidal behaviors or suicidality. And then suicidal ideation increased in both trajectories. So basically, social media use here was kind of very associated with an increased relative risk of these suicidal behaviors and ideations. In terms of mobile phones, there was the high trajectory had a large or the largest relative risk of suicidal behaviors at 2.17, which was statistically significant. Suicidal ideation had a relative risk of 1.5, also highly statistically significant. And then that increasing use trajectory had another statistically significant risk of suicidality with a relative risk of 1.22, also highly statistically significant. Video games also showed that the high trajectory compared to the low trajectory had higher suicidal behaviors and ideation with a relative risk of 1.54 and 1.53 that were both statistically significant, respectively. So kind of like takeaway here of this kind of outcome was that high or increasing use trajectories of social media, mobile phone, and video games use were significantly associated with elevated risk for suicidal behaviors and suicidal ideation in adolescents. And I think that that almost 20% of kids in this age group reported suicidal ideation. I feel like I ask this question a lot. I do not get those type of answers. I wonder if people are just not comfortable telling me.
Well, right. They're like, what is it going to lead to if I tell this doctor, yes, I've thought of suicide? Uh-oh, now I'm like forced to go see a therapist or I'm pulled out of school or something. My parents freak out. I could see that. Whereas if it's like a more anonymous survey, maybe you're more comfortable. Well, it's just and the connection is not just a little bit. Like the relative risk is greater than 2, for these like those high peaking social media use trajectory 2.39, like it more than doubles the risk.
Yeah, it's concerning. In terms of the mental health outcomes, and this was kind of from most of those parental scores like we talked about and the internalizing, externalizing symptoms. So when you look at internalizing symptoms, video game use, they had a high use. That was a 2.03 relative risk, so very high. Social media use also very high at plus 1.27 relative risk for internalizing symptoms. Externalizing symptoms was social media use that was high peaking at 1.25 relative risk, social media use increasing 1.05, and video games had a high but not as high at 0.94 relative risk of increase in terms of externalizing symptoms. And the difference between the two of them was kind of like depressive symptoms. Internalizing symptoms is more like withdrawal. Depressive symptoms, externalizing symptoms is more like acting out type behaviors, in case you want to kind of know what those two meant.
Mhm.
So this shows that kind of high video game use and increasing social media use are linked to significantly increase internalizing and externalizing symptoms here. So I think overall, kind of the trial does not look very optimistic for the use of technology kind of in this age group, at least from what I'm reading here. The question always becomes, will these results help me in patient care? As a primary care doctor, I find this article more relevant to my general practice than my addiction medicine practice. I know that I take care of kids. You don't, although adults are sometimes just big kids.
Totally.
I do spend increasing amount of time talking to patients about screen time. And, I feel like an old person saying this, but I feel like the more and more like people um, kind of talking to parents about kind of reeling in the unrestricted screen time use, about kind of the early introduction of cell phones into kids' lives, the unrestricted use of a cell phone and unknown access of what their child is using the cell phone for. I feel like I like kind of lecture people about these things quite a bit in my practice anymore. As a parent, I have a 10, a 7, and a 4-year-old girl, and I am not the cool dad. My parents are, my kids, like my 10-year-old is like lobbying so hard for a phone. And, I told her, I'm like, that ain't happening, man. I'm like, that check, I'm like, I signed that check. I mailed it. I put a stamp on it. That ain't happening for many years. And, she's not happy with us about that. But I do
Oh my
think that
god.
this study shows that I think there is real harms to it. I think increasingly I will continue to use this to focus on kind of a counseling component with my well child examinations. I think that this is a large prospective study showing that kind of these increasing use patterns do have a strong association. So I think this continues to add more kind of fuel to the fire that this is like a health concern to many of our youth. And I think it's interesting that kind of the screen time trajectory, not the baseline total use, had kind of the association here. And I think this kind of like really highlights the fact that like I think I need a better way to assess this than just asking how many hours like a parent or my kids are using their cell phone or using their tablet. I think we really need some kind of like real time tracking tools to identify which children are really at risk. So I'm sure that's coming down the road, some sort of a screening or some sort of a form that we do done in the office. But I think it's got to come at some point, I think, to help us out here in primary care for pediatric patients.
I guess my question to you is, do you think that I mean, I think the association in this study is pretty strong, but do you think it's causal? Or do you think that when kids become more depressed, they retreat into their phones and they withdraw from the rest of the world. It still doesn't mean it's not actionable. Like if a parent notices increasing amounts of screen time, it should be a red flag. But do you think the screen time is the cause? And forcing people to cut down on screen time would be therapeutic or not? Do you think it's just a signal?
Well, having recently completed my fourth or fifth statistics class this past month, I don't think any of these you can, there's no trial that's really going to probably be able to totally sort out if it's 100% causal. I do think though that there's some exploration here as to what we should be doing. And I think that we're gonna have to figure out some balance here, right? Because technology is integrated into everything anymore, right? So like my kids, they check the weather on Google Home when they're leaving to determine what to wear. School, everything's tech savvy, Google tech boards. I think we're gonna have to figure out what the sweet spot is. Like what's the sauce balance here to make this right? And I think you're gonna see in the next couple of years increasing amount of research that we're gonna be talking about this.
Yeah. Yeah, I think it's interesting. I mean, I work with not children, but a lot of young adults or I work with adolescents, 18, 19, people in their early 20s. And a lot of my people who are really stuck like in life, their life is not going the way they want. Screen time is a huge part of it. They all just say like they just scroll or they just game all day. Like they know it's not healthy and they find it very compelling and sort of compulsive. So I have also been counseling people about their screen time and their phone use, as a way to improve mental health. I don't really have strong data to back that up, but it's just kind of how I feel in my heart. Like they're not satisfied with that use of their time, you know?
Yeah, I think balancing technology. I mean, let's kind of say, like, I feel old saying this. I just turned 40, so um,
Congratulations.
yeah, I
Happy
did. And
birthday.
10 years ago, this wasn't even on my radar. Right,
Yeah.
this was not on my radar whatsoever as like a health concern. And I think now, not only is it on my radar, but I think that parents are viewing this as on their radar. I think society does as well. And like technology is great, but I think that there's adverse effects to it. I Now this is now off topic a little bit, but I saw a study just this past month about college students using chatbot GPT for 12 months unrestricted, and that they had fMRI data showing that their frontal lobe was underactive compared to those that didn't. Right
Their
after
frontal
12,
lobe, like,
a-
shrank. My god.
yeah, after 12 months of kind of heavy chatbot GPT utilization. I'm not gonna lie, son, I love chatbot GPT.
I know,
I
right?
mean, I feel like we're gonna have to figure these things out.
Yeah, I know. It's like the OxyContin of, you know, this decade. There's gonna be a lot of regret. You're gonna be writing a dear colleague letter of regret. Oh, well, thank you for presenting that article, John. It's just interesting. I'm a parent of 2 teenagers. I had, asked my older son, who's 19, if I thought he got a cell phone too early because both my kids, of course, have cell phones. They're age 17 and 19, and he didn't think it harmed him, but, he got his when he was in 8th grade. He said, "We coulda waited longer." You know? He didn't feel like it did him any favors by getting him a cell phone in 8th grade. So, um, maybe parents out there just hold off a little longer. John, I did want to share some comments. Our last article that you presented was episode 62 on oral versus extended release naltrexone, and that definitely inspired some people to write into the podcast. I wanted to share with everybody. First comment was actually from the author of the article itself, who sent us an email, Dr. Samet. He said, "John, you did a great job reviewing the details of the study and providing overall perspective. Just of note, we did want, because you and I have mentioned that where's the placebo arm? He said, just of note, we wanted the 3-arm trial with the third arm being no active receipt of medication as a means of documenting the impact of the medication compared to no treatment. This was rejected by the NIAAA, but we had the chance to do what we did, and we're grateful for that opportunity." I had asked why they rejected that third arm, which would have been placebo, and he said they just felt it was a settled question that naltrexone was better than placebo. So putting patients in a placebo arm was not really ethical or necessary for the study.
Hmm.
So I thought that was interesting.
Yeah, that's
Uh,
interesting.
we do got one more comment from another user on Spotify. Just said the article does elevate the option of oral naltrexone for me. Thank you for that article. And that it really did. Like I was kind of a hater of oral naltrexone for a while, and now I'm starting to use it more. Sometimes it's just practical. Like I do give the injectable form in my offices, but like it's annoying. It's expensive. You got to order it. You got to prior auth it. You got to get the big shot in your butt that people don't want to do. And I can write the prescription. The patient can have the medicine in hand in like 2 hours, as long as it takes them to drive to the pharmacy. So I've been using oral more and having patients who do find it effective.
I use both, but it is triggering when you like go all that work to get this medication approved and it's expensive and then it sits in your fridge.
Yeah.
And the patient never comes back and you're like,
Well, right. We throw out tons of unused medication that we can't repurpose for other patients. It's depressing. And I think the patients also feel a little bad about it. Um, we got one more comment also about that episode 62. It was about our preamble. We talked a little bit about buprenorphine dosing. And this was a listener, Kate Macaron, and she said, I found the preamble discussion of this episode so interesting because things are obviously so different in Australia, she must be in Australia, versus the US. We have universal health care, and it is extremely common for patients on sublingual buprenorphine to be on doses of 24 to 32 milligrams per day long term. So I don't know, Kate, maybe we'll be moving in that direction in the US. I think the high dosing of buprenorphine is just being more and more promoted. I've seen several articles recently looking at doses of 32 milligrams. So it's interesting that in Australia, that's the standard.
yeah, that's a nice way of saying the preamble that we were just rambling.
The preamble. Yeah, it makes it sound very official. Thank
That
you,
sounds
Kate.
like nice. It's like rambling and lunatics at 10 o'clock at night.
Lunatics. It's not 10 yet. Soon now. But anyway, we love the comments. Keep them coming. If you are listening and you want to say something about the article, please, you can email us. You can put a comment on social media, especially Facebook, Instagram, Threads, whatever else. We're on them all. YouTube. You can send us our work emails. You can Google us. Anything. Just send us your comments. And thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation. We want to hear what you have to say. So please send us your comments on social media or join our Facebook group. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Keenan and Ars Longa Media. The Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.